Welcome. I'm Clara McKay, CEO of the World Ovarian Cancer Coalition. And firstly, a huge thank you to the London Global Cancer Week team for inviting us to take part in these proceedings. We're delighted to be here today and delighted to share the work that we're undertaking in partnership with the International Gynecologic Cancer Society on the Every Woman study in low and middle income countries. And we'll be hearing from IGCS's CEO, Mary Eichen, a bit later in this session. A few quick words about the coalition. Our vision is a world where every woman with ovarian cancer has the best chance of survival and the best quality of life possible, wherever she may live in the world. And we work to empower the global community through knowledge, collaboration, and action. So we work with just under 200 patient advocacy organizations worldwide across more than 50 countries, and they represent a really diverse community geographically across all income settings, operationally in relation to their size and the resource that individual organizations have, also in relation to their focus of work. So ranging from organizations that focus specifically on ovarian cancer through to organizations that work on gynae cancers, women's cancers, and generic cancers. So today we wanted to share with you our work on the Every Woman Study Low and Middle Income edition. You'll hear today some firsthand reflections from our team in Malaysia, the first country to start data collection. We'll share with you findings from extensive interviews that have been undertaken with country lead clinicians. We'll have a discussion with 3 country leads on how we turn data and intelligence from the study into real action. We'll share some of our reflections on the challenges of setting up the study and the importance of key partnerships and relationships. And finally, and importantly, there will be a chance for those attending today to share your thoughts on what you've heard, and we're really interested in your views. Please do contribute. You can put your any comments or questions or observations in the question and answer box. We'll collect them as we go along, and we have left time at the end for discussion. So for more information about the study and the work of the coalition, please do visit our website or use the QR code on this slide, and please do not hesitate to get in touch. So on that note, it's my great pleasure to hand over to Frances Reed, Director of Programs for the Coalition and Study Director for the Every Woman Study 2018 and the more recent LMIC edition. Frances will take you through the background to the study and also share some insights from data collected to date. So Frances, I'll hand over to you.
Thank you very much, Clara. I'm just going to share my screen. And while I do that, say a heartfelt thank you to London Global Cancer Week for giving us this opportunity. So I am going to take you through the background, the development and results to date. I'm just going to play from the start. So I'm not going to assume that you know a lot about ovarian cancer. You may or you may not. It's a difficult disease. Diagnosis is most common in late stages, and 70% of women face recurrent disease as they go through the journey. There is no screening test available, and symptoms are common in other illnesses, so often ovarian cancer is not considered, and that's why for a long time it's been thought of as too difficult. However, increasing evidence shows that 9 in 10 women display symptoms regardless of the stage or type of ovarian cancer they have. Delays in diagnosis are very common. Many women are often too poorly on diagnosis to even start treatment, and that is including in high-income countries. CA125 and transvaginal ultrasound, which were the component parts of the screening program which failed, can be used effectively to diagnose symptomatic women, but it needs understanding. Symptom patterns and age can be important distinguishing features. And when women actually do get on time to good surgery and standard of care treatment, there can be a lot of benefit. So my answer to, is it too difficult? The answer is no, we can do better. So in terms of other gynecological cancers, here are figures which I extracted from Globocan from 2020, showing the split between high and low and middle income countries. So we have incidence on the left, mortality on the right. As you will see, cervical cancer is by far the biggest burden, as you already know, and quite rightly is the focus of a lot of attention now with the cervical cancer elimination strategy. But if you look, there are very significant numbers of ovarian cancer cases in low and middle income countries. In fact, 70% of women in the world who have ovarian cancer live in these settings. When you actually look at the mortality, if you had a woman with ovarian cancer and a woman with cervical cancer, it is the woman with ovarian cancer who is most likely to die. Ovarian cancer survival rates are still poor. A little bit about the standard of care and some new developments. So standard treatments are platinum and taxane combination therapy for the main types of ovarian cancer, and they have been around for decades. And all of the standard treatments for ovarian cancer are on the WHO essential medicines list, and they can bring a better quality of life for women and some good results. Up to 20% of women have a BRCA mutation, either germline or somatic mutation, connected to breast, prostate, now pancreatic cancers. Family history is really important in this context. Their mother's side of the family and their father's side of the family. Women who have BRCA mutations are more responsive, in fact, very responsive to PARP inhibitors. And they have a use in more widely in other women who have other forms of homologous recombination deficiency. So there is hope and progress on the treatment side of things. But accessibility and affordability are key issues. So in 2018, we wanted to establish a patient experience evidence base. What was it like to have ovarian cancer around the world? We developed an online survey, an extensive one, which was completed by 1,531 women in 44 countries. And those countries on the right are the countries that had respondents, and the larger the lettering, the greater the number of respondents. And we got sufficient numbers that we were able to extract some important differences between those countries. Our results were published in the International Journal of Gynecological Cancer in 2020, and they showed a common set of issues, but each country had a different mix of those issues. No one country was without any issues, and the potential to learn from each other. A quick example, in the UK, where I'm based, women know about ovarian cancer more than in other countries. More women go to their doctor about symptoms for the disease. They don't necessarily go very quickly though, and when they go to the doctor, they face long times between that first visit and their diagnosis. And overall, that difference in time to diagnosis varied by 3 to 4 months between countries like the UK and US versus countries like Japan and Germany. And there were differences in genetic testing. Germany, that did well on diagnosis though, still had a large proportion of women for whom surgery was done by gynecologists with no specialist training in ovarian cancer. So there was a lot of room for improvement, but there was a big caveat for the data. 95% of our respondents came from high-income countries, reflective of the fact that it was a long online survey, even though it was in multiple languages. So we wanted to do better. And this is why we have set about developing the low and middle income edition. The other reason is because of the projected increases in incidence to the year 2040, you can see really quite significant increases in incidence and mortality. When you look more closely at the figures, you will see that developing countries will be hit the hardest. So Europe will see just under 10% increase, versus Africa, likely to see a nearly 90% increase. This is going to be a big issue going down the line, and particularly as the burden of cervical cancer reduces, this will be coming up behind. So it's important, we think, to consider what we can do now. So our intended outcomes are that we develop a global data set, but also countries have a national data set on a range of key patient experience issues that can provide them with direction on practice and be used to advocate for change. There'll be opportunities for all to publish key findings, global, national and international levels, to add to the knowledge base. We'll be able to provide comparability between countries. We've asked them to collect minimum sample sizes. And there will be, importantly, opportunities for clinicians and women who have ovarian cancer to work together to inform and promote advocacy efforts. Perhaps that's with existing groups in their country or even establish new groups. Developing a collaborative voice, bringing ovarian cancer to the table with everybody else. We created an oversight committee who will be listed at the end of this presentation. I call them the Insight and Oversight Committee, who really helped us adapt the original survey. In order to get the women to participate, we decided early on it had to be through hospitals. And that meant we had to take the length of the survey right down. So it was reduced in length to 1/3 of the original, but all the core areas are covered. We discussed extensively how we could deliver the survey. We tested it in a range of countries, and we decided that clinical staff would actually give additional information about the women, such as their stage of diagnosis, their type of ovarian cancer, what treatments they had received, and so on, and what was available in their country. And we decided to interview lead clinicians and then gain further information from them via surveys. So the areas of questioning, they range from demographics, family history, the journey to diagnosis, who did they visit, how often did they see somebody, did they know anything about ovarian cancer, what symptoms did they experience. Treatments, not so much which treatment did they have, the clinicians answer that, but what have been the effect of treatments on them? What has been part of their decision-making process about whether or not to have treatment? We've also looked at their emotional support needs, their practical and information needs, and what is important to them, their priorities, and what is important to them in terms of their quality of life. Often when we talk about cancer care in low and middle income countries, there's a strong focus, and quite rightly, on access to diagnostics, surgery and medicines. But there are all these other barriers around that get in the way of access. And depending where you are as a woman, wherever you live, you will have a different route. You will meet different barriers along your way. Some will be bigger than others. So this is why the patient experience at a country level is going to be so important. Each country will have a unique mix to address, and they will have that information to hand. So we are well underway. We have 24 countries participating, spread geographically and across the income bands, and 130 hospital sites now. Each country was given the chance to have up to 10 sites to try and get a broad reflection of care in their country. But, you know, in some countries, there is only one place where women can get treated for ovarian cancer. We do know that we will miss those women who never get the diagnosis and never make it to their centres, but this is data we can actually gather, so this is where we start. We've worked hard to make it accessible. We have 31 languages now. We've gone with whatever the country teams wanted for their communities, and women can participate in a number of ways according to what is most appropriate for them. There can be a secure email link, a WhatsApp link, they can do a paper copy in the clinic, or they can have somebody sit with them and take them through the survey. Even before we started data collection, we've seen some early outcomes, improved women and clinician interaction, development of novel patient information, women being referred on for counselling or for financial support to NGOs, and first-time engagement of some clinicians with advocacy groups in their country. I thought to give you just a little bit of data so far. This was literally yesterday. So far, we have 9 sites in 5 countries collecting. Malaysia, Kazakhstan, Brazil, Kenya, and Argentina. 179 women have been through the process. High-grade serous is the most common. So far, nearly 7% haven't had surgery and 20% no chemotherapy. That may be because they're quite recently diagnosed. We'll look into that. Average age, 51.3, 53 for the median, and as you'll see, most commonly stage 3 diagnosis. Things like, more than 10% have travelled for 5 hours or more. 3.4% have travelled for more than 24 hours to get to their hospital. This will change as we add in the mix of countries. Over half have caring responsibilities for children. Nearly 6 in 10 are in employment. This is not a disease of the elderly. These are economically active women who are contributing to society. Just 13% haven't experienced any of the classic symptoms of ovarian cancer, and only 27% believe their time to diagnosis could not have been shortened. Nearly half report that treatments are free in those countries. A third report that diagnostic tests are free, so that means nearly 70% aren't free. 40% have personally paid for treatment. Family members have paid. They've even resorted to crowdfunding to find money. And more than 30% say their family finances have been affected to a great extent. So our data collection goes on until the end of June next year, where we hope we will have got every country to its minimum sample size. We'll continue our interviews with lead clinicians, but you'll hear the interim findings shortly. There'll be the global analysis and country reports. Country leads will identify their national priorities. We'll work on publications and dissemination plan. And importantly, we are already trying to seek funding for projects that can come out of this, for groups in countries to directly address specific issues that relate to them. Huge thanks to our oversight committee who are listed here, some of whom are also country leads. Our country leads have been amazing at making this happen. They've stepped forward. They have fought through the barriers of translations and ethics approvals and coordinating and gathering people together. So we really would be nowhere without their involvement. And we've still got a long way to go to get everybody on and contributing data, but we're on our way. And as Clara said, Malaysia was our first country to start collecting data. And that's thanks to their country leads, Professor Wu Yinling and Yoon Suk Yi, out of the University of Malaya Medical Center in Kuala Lumpur. And they, together with their team and patients, they are already finding benefit in participating in this study. And they, together with us, have put together this video to share some of their findings.
So one of the real benefits of participating in the Every Woman study was the fact that we could get opinions and how patients and women felt themselves. As clinicians and healthcare professionals, we got a rough idea, but we've never really documented them properly and systematically. And this study has really allowed us to do that and to really meet women everywhere throughout the countries in the different states where women are participating. And it's allowed us to speak with them in their different languages and meet them at their point of need. We've met lots of patients now where we explored areas that we've never done so before, particularly during the time of the COVID pandemic. The other thing that's really good that has allowed us to engage with patients more is in terms of the family and the social demographics, their financial situation, and how their family members play a role in their decision making. A few patients are quite excited to find out that their opinions will eventually form policy and for us to advocate for them. And I think that's a very powerful thing which we hope will come to fruition in the near future?
My name is Catherine. I'm 62 years old, married with 2 grown children. When I was diagnosed, I was very overwhelmed because it came as a surprise to me. I do not have much of a symptom, and so when I was not well, I went in and they told me and they diagnosed me as cancer. So upon diagnosis, many concerns came to mind. One, of course, is the financial aspect. I do have an insurance policy, but my policy, they exclude gynecological condition. And other concerns that come, it's care, physical care, because I was quite weak at the time. And I was very concerned as to how do I get the help and the care that I need. And then, the other concern is, of course, the emotional part. Having cancer and going through the journey is it's actually a very lonely journey, where I think not many people can fully understand what a cancer patient has to go through. We also have this fear, this uncertainty of what lies ahead, this anxiety.
好，so 我叫 Yuki， 我今年23岁，我目前是有在一个民宿做 part time 啦。在去年2021年，我确诊了卵巢癌第3期，然后我是有 BRCA2 positive 的，然后在去年9月的时候完成了我的手术。so 我在确诊了这个癌症过后，我没有办法工作。so 本来我是在新加坡得到了一个，就是完成了我的一个奖学金的学习过程，然后要继续在新加坡工作6年。可是因为确诊了这个病， so 我必须要赔偿他们的 scholarship， so 这是对我的一个工作方面还有经济的影响啦。然后可是除此经济方面的话，因为我们是在UM 是半政府，so 花费总额来讲还是觉得是 OK 的，可以负担得起的，只是标靶药对我们来讲是负担有一点重啊。
Hi, I'm Irene. 3 years ago, I was diagnosed with ovarian cancer stage 3, carcinoma sarcoma. I never heard of ovarian cancer before this. I wish I knew the signs of ovarian cancer, and so I can know the bloatedness, eating less and feeling fuller, indigestion sign of this, and I can handle this better. But because no awareness was there, so totally ovarian cancer is not in my diary. I'm not going to say that it hasn't changed me or shook my soul and made me who I am today. See, so the world I see now is not the one I knew before I was diagnosed. So I can say that my view has been shifted, and I know that we should not let our cancer diagnose or define us. And I feel that with these studies, then we can move forward. We can have better support from our government, from our friends, our family, who are not aware of what is ovarian cancer. We can tell the doctor, because sometimes the message given to the doctors by us as a patient, we cannot be specific because we are not sure whether this is the right feeling. But when we have a support as the patients together, and then we have when we talk to them, those who experience example, then we will know what to tell the doctors.
I hope that by me briefly sharing my experiences will be able to help to have more facilities and support groups established in the days ahead to benefit other ladies who are diagnosed with this kind of cancer.
Hi, I'm Dr. Yogi. I'm an obstetrician and gynecologist here in University Malaya Medical Centre, Kuala Lumpur. Here in UMMC, we strive to provide better care to our patients who are diagnosed with ovarian cancer.
Hi, I'm Dr. Teo from University Malaya Medical Centre. I'm a gynecologist here. The COVID-19 pandemic has had a major impact on provision of care for our patients. The Every Woman study will highlight how we serve our patients and our local resources are stretched.
Hi, I'm Dr. Ruben. I'm an obstetrician and gynecologist here in University Malaya Medical Centre. As we consider treatment options for patients, we may not always take into consideration patients' perspective, and this study helps us understand them better.
Ovarian cancer in Malaysia has always been seen to be like a hidden cancer, mainly because of its perceived poor survival. So much so that there hasn't been any groups of support system for the patients that has been set up previously. However, when the opportunity to take part in this Every Woman study and seeing how successful it was in the first part, it gave us an excuse, in a sense, or a chance to bring together a group of survivors. And we realized that when we actually tried it, there were actually many survivors who were keen to come forward and to be part of this support system. And hence, because of being to participate in this EWS, we now have Ovarian Cancer Malaysia, which is a support group for ovarian cancer patients in Malaysia.
So when I participate this, I hope that the more doctors knows how to identify the first start of ovarian cancer, because when you have this at the early stage, it's better control than later stage. Usually by the time that the patients now have been diagnosed with ovarian cancer, is already a very late stage. So with these studies, then we can know that, okay, Asian women are different from the, all the European women or the Americans, because in Asia, we have not have this study also. I do hope that, all these data, more doctors can diagnose or can identify. I just hope that this will be the one.
因为我希望可以通过这个 study 提高人们对这个卵巢癌的预防意识，因为只要是就算在很小的年龄，比如我这样22岁就可能会得到卵巢癌了，就是不要有侥幸的心理啦，希望大家都可以提早发现并且预防，然后不要害怕确诊，因为我们永远有一个组织在后面帮助还有支持你。
Being part of the study also means that we as clinicians and healthcare providers can network, and it is amazing how just in one study we now have many centers throughout Malaysia in many different states that now work together and have our patients give us their information and their opinions and their feedback, so that this is truly a representation of the various groups of patients throughout Malaysia. So this is the first time that in Malaysia we can actually get all of the patients from all different geographical parts but also different ethnicities, for us to be able to understand their needs and be able to support them better. So this has been an amazing opportunity, and we are already starting to see the benefits with more discourse and with more discussions among the clinicians in different centers throughout the country.
That was Yoon Suk-yi ending that video report, and thanks to our amazing Malaysian team. It's been and is a real privilege to work with them, and to Irene, who featured on the video as well. She is one of our Asian patient advocates on the Oversight Committee. So I mentioned earlier that we are collecting important information from our country leads on the state of care for women with ovarian cancer in their country, the challenges and the opportunities that lie ahead. This will provide important contextual information for our global and national analyses and subsequent reports. We'll hear from 3 of our country leads shortly, but as a first step, in the information gathering process, we're going to hear a summary to date of our interviews with those lead clinicians. Anmol Bajwa is our research assistant, and she has been carrying out these semi-structured video interviews, and she will present to us her interim findings.
Thank you. As part of the Every Woman Study LMIC edition, semi-structured qualitative interviews were conducted with participating country lead clinicians. Country lead clinicians are responsible for leading data collection in their respective countries. As we know, a paucity of ovarian cancer data in low and middle income countries prevents obtaining a comprehensive understanding of the factors that underlie ovarian cancer health outcomes. Therefore, the interviews aim to explore clinicians' perspectives on the key issues and challenges in ovarian cancer care in their countries, the cultural contexts affecting access to care such as treatments and diagnosis, the impact of the COVID-19 pandemic on ovarian cancer care, and future opportunities for improvement. After conducting these interviews, a thematic analysis framework was used to extract emerging themes from the data. This is an ongoing process as we continue conducting qualitative interviews from other countries as well. The information in this report, gathered from video interviews, together with further detailed written responses, will provide context for the overall and country findings of the Every Woman study. So far, we have interviewed the following 15 countries, 3 of which are low income, 7 lower middle income, and 5 upper middle income. The following common themes emerged. 100% of the clinicians highlighted that the quality of ovarian cancer data is not adequate. Out of 15 countries, only 2 have a national cancer registry with ovarian cancer figures. Other low-income countries have more city-level cancer registries, but that too only for certain cities that are equipped with the necessary resources. Some other countries collected data at even more local levels, such as at select tertiary government hospitals. These contribute to serious gaps in ovarian cancer evidence and data. Dr. Benima from Morocco echoes the need for more context-specific ovarian cancer data.
We need epidemiological studies so we can understand the risk factors, the way cancer is in the country, and so we can address approaches, but they are adapted to our local context. We cannot have approaches from European countries or American countries and apply them to Moroccan population. I think this is the case for cancer in all the globally. We need local actions that are specific to each country and to each community. And for this, we need data and studies that explain the cancer in each country, or even on each area, or each, I don't know, maybe in each area. Maybe because even in Morocco, the distribution of cancer cases isn't the same, and the risk factors aren't the same. When we talk about South Morocco, where the population is much more vulnerable and poor and have less access to treatment facilities and medical facilities, it's not really the same thing when we talk about Casablanca, Rabat, when it's the center, when everything is closed, when they have much more money, much more investments. Okay, even in one country, there is this gap and there is disparities. So we cannot apply one approaches to all patients in one country or even in several countries.
In addition, about half of all countries acknowledged the lack of preventive evaluations for ovarian cancer. There was consensus that countries do not have equitable access to genetic testing. Even though country-to-country variations exist, and a few do have some access to genetic services, there are inequities in that they're only concentrated in certain urban areas. Where women live, their socioeconomic status and a lack of awareness about the benefits of preventive evaluations interact as factors to result in genetic testing not being used to its fullest potential for preventive goals. Consequently, late-stage presentations are the result. It is also important to highlight that most participating countries do not have adequate diagnostic infrastructures. Given such inadequacies in more than 55% of the countries, access to diagnosis was further limited due to out-of-pocket expenditures. Given that ovarian cancer care is a continuum, if women are not able to access diagnostic services, they might never be able to reach the treatment stages. For low and lower middle income countries, this idea of opportunity cost was also highlighted. Since these countries must continue to address the burden of communicable diseases, most resources must be diverted towards such diseases. Therefore, there's often this opportunity cost of not using these resources for investments in developing more robust diagnostic infrastructures for cancers. These countries also rely on drug imports and face regular stockouts due to patchy supplies. Even for Kazakhstan and Malaysia, the two countries with relatively better access to diagnostics and treatments, access to newer targeted therapies is still very limited. Therefore, clinicians suggest it is important to work on finding a way to improve the affordability and encourage research initiatives and clinical trials in low and middle income countries so treatments can become more accessible and affordable. When it comes to health literacy, 100% of the countries mentioned lack of awareness of ovarian cancer as an issue. They highlight that this lack of awareness about ovarian cancer in the presence of urban-rural disparities impacts on rural women more disproportionately. There was consensus that there is not enough information to ensure confidence in healthcare and/or to encourage health-seeking behaviors. Many countries also mentioned the wide availability of alternative treatments through local healers. But at the same time, they highlight that it is important to note the intersectionality between inaccessibility to care due to where women live, their socioeconomic status, and availability or reliance on alternative treatments. Dr. Connie from Ghana highlights this issue of health literacy even further.
Sometimes, even if they are told that it's more likely to be an ovarian cancer, the cultural belief is that you can't have a cancer. There's something, or somebody has bewitched you, somebody has planted something in your abdomen and it's growing that fast, for which reason you don't need medical or surgical care. What you need is a spiritual or any other form of treatment. That is going to be by herbal treatment. And most of these patients are given concoctions to drink, concoctions to even use as enema. The enema, you'll be told that, yes, this is going to let whatever is in your abdomen come out after the enema. So they'll do all these things, these things don't work. Then the other social one is not coming to the hospital, but going to see spiritualists and some, I'll put them in quotes, local, they call them surgeons, because what they do is they use knives. They don't do surgeries, but about 75% of our women who come in with the enlarged abdomen always have some scarifications made on their abdomen. Scarification marks made by either broken bottles or by sharp knives.
Several countries also highlighted ways in which patriarchal family structures, women's place in society, and care autonomy operate as factors to affect healthcare access and outcomes. Illiteracy creates dependency on men in the family for accessing care. For example, it was highlighted that in the lower income countries, it was usually at the husband's will that decisions regarding money for medical care were made. Clinicians suggest that pushing for community and intersectoral partnerships to improve advocacy and awareness of ovarian and other cancers, the role of women and value of medical intervention with focus on involvement from ovarian cancer patients and survivors is essential. As we know, the pandemic also presented a number of challenges. Some of the sub-themes that were analyzed include lockdowns and disappearances, repurposing of resources to the pandemic effort, change in guidelines, clinic closures and impact on diagnosis, and supply chain issues affecting treatment availability. Dr. Paria from Nepal highlights the impact of the COVID-19 pandemic on ovarian cancer health outcomes, as well as access in Nepal.
A very sad incident. I do remember it was almost 1.5 years ago when COVID situation was pretty bad and the country was in lockdown state. So there was a lady who was brought to my center in Kathmandu in ambulance because it was allowed even during lockdown state. And she was from far western side, almost more than 500 miles from the capital city. And they said it had taken around 18 hours of drive. Of course, the 500 miles in Nepal, like due to difficult terrain, it takes a lot of time. And this lady, she was young, newly married. I think she was around mid-20s, did not have child. And she had gross distension of abdomen and she was kind of bedridden. So she was brought quite late, very late in fact. And when we asked why, they said, number one, due to lockdown state, again due to COVID. Number two, they had to gather financial resources and they had to pay 2 to 3 times more for the ambulance than the regular on regular days. So this all kind of caused delay. So we counseled her regarding chemotherapy and they said they will go home, get prepared for chemotherapy and come. Unfortunately, the lockdown extended. She could not come and we kind of followed her up by phone and they kept on saying that they were gathering resources for treatment. And she defaulted for almost 3 months.
While there are many commonalities in the kinds of issues faced by these countries, there is also variability in the nuance and extent to which certain issues impact on ovarian cancer care and outcomes. Finally, despite many significant challenges, clinicians emphasize that there is no shortage of opportunities for improvement. A multi-sectoral, patient-centered, and collaborative approach is needed to ensure more equitable ovarian cancer health outcomes. Quantitative studies that assess cancer burden in lower and low-middle income countries, coupled with qualitative studies that aim to understand context-specific shortcomings and future opportunities, are required. Our next steps are to complete the remaining country interviews, review the analyses, complete the report highlighting these themes in depth with a view towards publishing this work in collaboration with the Oversight Committee and the country leads. Thank you.
Thank you, Anne-Mark. And for those of you watching the webinar live, please do feel free to comment or ask questions using the Q&A function. We'll come to them in a short while. We'd love to hear your thoughts. well, to give their own thoughts and to discuss how we can turn the findings of this study, when they come through, into tangible action that makes a difference for women. I'm delighted that I am joined by 3 of our country leads. I'm going to introduce you to Dr. Aisha Mustafa. She is a consultant in gynecologic oncology at Ahmadu Bello University Teaching Hospital, Zaria in Kaduna State in northern Nigeria, and she's also a senior lecturer in the affiliate university. We have Dr. Afrin Fatima Shafi, who is in her final year of gynecologic oncology subspecialty training at Moi Teaching Referral Hospital in Kenya, and she's also a fellow of the International Gynecological Cancer Society. And last but definitely not least, Dr. Tracy Adams, who, in addition to being our co-chair of the Oversight Committee, Tracy is a clinician specialist in obstetrics and gynecology and a subspecialist in gynae oncology in Groote Schuur Hospital, Cape Town in South Africa. Now, each of their countries operate differently in terms of funding structures, and to varying degrees. Some have national health insurance, but perhaps only for very limited groups of people or certain conditions. Might not even include cancer. Some might provide a limited amount of free treatment, but diagnostics are out of pocket. Some have private insurance, but often women are dependent on their husbands and so on. So there's a lot of challenges within this group and a lot of variation. I'm going to ask each of you now in turn, having contributed to the clinician interviews already, some or most of the themes that you've heard will probably not be a surprise to you, but I'd like a very quick initial response. Then I'd like to hear, what is your greatest frustration when it comes to progress? And if you can give us an example of how a woman you have cared for has been impacted by that frustration, that would be great. And I'm going to come to you, Aisha, first of all.
Thank you very much, Frances. For me, my greatest frustration caring for women with ovarian cancer is actually funding. It is of very big concern to me because most of these women that we see here in northwestern Nigeria are women coming from low socioeconomic, they have low socioeconomic status. They are largely unemployed. Some of them are peasant farmers, petty traders, cattle rearers, and they cannot afford their own care. And as such, in order for us to close the gaps in diagnosis, the equity gap, the treatment care gap, we need to close the funding gap. We have to find a way to grant funding for this woman to be able to treatment for their ovarian cancers. And this funding inequities are actually seen even within Nigeria. For example, very big cities like Lagos, where the population the households have over 70% of wealth quintiles being in the highest, compared to some places in the northwestern part of Nigeria, where this figure is actually less than 5%. So a woman having ovarian cancer in the northwest and in Lagos have different access to funding for their care. And there are also interventions, for example, like the Cancer Health Fund by the Federal Ministry of Health. It currently does not cover for ovarian cancer care. We also have the National Health Insurance Scheme, where, as at the National Demographic and Health Survey of 2018, only 3% of men and women in the reproductive age group actually have access to it. This figure is probably higher now, but definitely still less than 10%. And as such, even people there's a very limited population that have health insurance. And even when they do, it doesn't cover for every aspect of ovarian cancer treatment, even though other initiatives are springing are benefiting. For me personally, I see women who struggle to pay for even diagnosis, and as such will probably never get to treatment. Some of these women die without a diagnosis of ovarian cancer being made, despite having features highly suspicious of the disease.
I remember a woman I saw precisely late September this year, who came to me with features highly suggestive of ovarian cancer, and I wrote the most basic investigations, tumor markers, a transvaginal ultrasound for her, and some other blood investigations, and she couldn't afford it. And she told me specifically that, please, can I come back after the harvest and after I have sold my farm produce so that I return to have these investigations done. I mean, this is so disheartening for us, and we tend to see this very frequently where women couldn't even pay for their own diagnosis and will definitely probably never get to treatment.
Thank you, Aisha. Afrin, would you like to pick up on that? Is your frustration similar?
Yes, Francis. So we here in Kenya face similar challenges as well. One of my main challenges or frustrations as a clinician is for our women being able to afford, not only afford care, but also to sustain care. So around 36.1% of Kenyans live below the poverty line with a monthly income of around $30 to $50. So they're not even able to afford the basic care, let alone the basic health care. Most of our women don't have access to treatment. However, the Kenyan government has implemented certain schemes such as the local national healthcare scheme that has helped considerably. However, the scheme actually covers up to 80% of the care. So most of the time patients have to top up in addition to complete their care. Other times they end up depleting their insurances, so they have to wait for family members to raise funds. This leads to substantial delay in treatment. Sometimes women altogether abandon treatment, you know. For example, let me give you an example of a woman that I saw. She was one of my first patients I saw when I joined my fellowship training. She was a young woman, 33 years of age. She came to us when she was pregnant at around 20 weeks. So this woman actually had ovarian cancer. She had undergone surgery. Following surgery, she needed chemotherapy to at least complete her treatment. But unfortunately, after receiving the first cycle of chemotherapy, her husband abandoned her and he dropped her out of his insurance. So this patient was completely financially dependent on her husband. So she was not able to get the necessary treatment. We lost touch with her. We tried to contact her. The hospital made several attempts to contact her, but we were not able to. The next time we saw her was when she came for her delivery at around 38 weeks. We delivered her, but at this point she had come using a different name, so we were not able to initially get who this patient was. Later we were called on board, then we went through her previous files. Again, following the delivery, she delivered a healthy baby. Then now, again, she needed following treatment. But to this point, she was still not able to get any support, any financial support whatsoever. And she disappeared after the delivery. We saw her later, 6 months later. She came with a very advanced disease at this point, you know. So she was taken, she had this abdominal mass. So we took her to theater again. We operated on her, following which somehow her brothers and her family had collected some sort of funds for her. So she got she got the necessary chemotherapy after the progression of the disease. However, then after that, she has been on follow-up. Just 2 months back, I saw her again. Now she has developed a recurrence. But after we gave her 2 cycles, now her insurance is completely depleted. She doesn't have any insurance. So again, we are there. We don't know what to do. We've tried to engage some of the social workers and the hospital to see if we can waive some funds, but this is common. Every other woman's story is the same. So we need some sustainable source or some sort of sustainable way where we can actually offer treatment to these women. So it gets very difficult to treat our patients. It's very sad, especially particularly the younger women who can, you know, that they can be potentially cured and they have a good prognosis.
Thank you, Afrin. Very moving. Tracy, can I turn to you? Do you share similar views?
Yes, indeed. Thanks, Francis. I think in South Africa, like many other low middle income countries, we have lots of diversity. So we have huge differences between our rural communities and our more urban communities where you may have more surgeons available. I think one of my frustrations, as I'm sure is shared with many other countries of low middle income, is lack of political will. I mean, we know the disease, we know what needs to be done, but we need more policy that drives things. But besides political will, we got in terms of politicians, also acceptance of the status quo amongst healthcare workers, for example, as well. And an example that I will give is during COVID, our surgical lists were cut. And in an urban area, we resumed those, but not completely. And the acceptance that this is acceptable for women not to have enough, we've got enough surgeons, but in terms of the theatre time. There's also competing needs in terms of emergency theatre, where women have to compete with things such as trauma, instead of having lists specifically for women's care. I feel very strongly about that, and I think that we're not the only country that women always have to compete with other disciplines.
Thank you. Hopefully data, we've heard about the lack of suitable data, but hopefully it will help contribute to pushing the case forward in your countries. If so, how do you think? I'm going to come to Afrin first on this.
So yes, we do definitely have a deficit in terms of record keeping and submitting the relevant data to a central database, which is common with every other low middle income countries. The other thing is what we may see in these databases may not be reflective of what is actually happening on the ground. And in order to make change or implement any sort of change, we need actual numbers. So currently we know that cancer research is heavily skewed in the high income countries. We're using data from the high income countries, which may not be relevant in our setup. We need research in our low middle income countries, which is relevant to the problems in our countries. So for instance, if you look at the Every Woman studies, it highlights some very pertinent issues that are actually common in our situations in our low middle income countries. I think women are, with what we're seeing, the data we're getting, the kind of data we're getting, we're seeing that women are voicing their opinions. We are seeing what the challenges are. I think this in the long run will help us drive advocacy and probably make changes where we see now what are the deficits and make the changes in those areas.
Yeah, thank you. Aisha, I know data record keeping in Nigeria has come on quite some way, certainly with initiatives that you've been involved with. What is important about this data really to you?
Thank you very much, Francis. I actually believe that the Every Woman study will contribute significantly to actually improve our record keeping, not just for ovarian cancers, but even for other cancers. And just as Afrin said, it's actually very important that we own our own data and not just quote figures from other populations and then extrapolating such findings into our own populations. It is important that we have our own local data, and the need for this cannot be overemphasized. For example, we do not know the actual prevalence of ovarian cancer in Nigeria. This is because significant proportion of these women never even come to the hospital, and they die in the communities. And even for those that come to the hospital, as I have elucidated earlier, they might even die undiagnosed. Now, for the small proportion that gets to have a diagnosis, the pathology records are not in tandem with the records in the clinical arm of the hospital. For example, retrospective studies that we have tried to do to look at ovarian cancers in my institution have shown an almost 50% drop in case notes retrieval, meaning from the pathology records, you can get probably 20 cases over a period of time, and then you get less than 10 of such case notes to actually review the data. So eventually we find that even for those women who were diagnosed and are within the hospital, we cannot get quality data from this. And so leveraging on the Every Woman study, which is actually the first ever documentation of patient experiences with ovarian cancer from pre-diagnosis to post-treatment, and is touching on the entire care continuum for ovarian cancer will actually help us to have a platform that we can leverage on for record keeping for our ovarian cancer patients. And this will help women in such underserved and usually overlooked settings like ours for us to be able to see an impactful way forward for change in regarding record keeping. For the records we keep currently, we mainly use the analog data. We have not gone fully electronic. And at sometimes the entire booklet in which these cases are being recorded is missing. And even when they are found, they are sometimes destroyed and you cannot get relevant aspects of such data from the case notes. So we are hoping that Every Woman Study will be our own platform for commencing record keeping and then leveraging on the available technology, and then even further collaborations and partnerships.
Thank you, Aisha. And Tracy, I think you have a thought about, the importance of it being South African data too.
Yes, I think historically there's always been some mistrust of the global north coming in and doing research and taking it away. So I think the Every Woman Study is given the opportunity for researchers, as mentioned before, to essentially empower researchers in low middle income countries, to involve them in the data collection and allow them the opportunity to grow as well. So I think it's a fantastic initiative in terms of data collection.
Good. I want to ask you also now about the importance of health literacy. This is for Tracy. Just briefly, because we're running, getting tighter on time as we go forward. Why do you think health literacy, we're moving on from the data issue now, is so important in your community?
I've done some advocacy in my country in terms of community engagement, and what I've learned is that women know very little about their body, not all, but some of the women that I serve, where we actually have to draw drawings and show them what part of their anatomy is what. So I think it's really important before you can educate about disease that they understand their bodies. So I do feel strongly about health literacy.
Yeah. And Aisha, what role does civil society play, and what do you think it can bring in Nigeria?
Thank you very much, Frances. For us in Nigeria, I think there's a very big role for non-governmental organizations and civil societies to play, and they're actually doing an amazing work in cancer advocacy, even through diagnostics, funding for treatment, and also survivorship. However, in my own opinion, I feel most of those civil society organizations focus more in the urban areas, and the women in those urban areas they have higher socioeconomic status, they are more educated, and the women in the rural areas that actually need more of this awareness creation are usually left out in the activity of these organizations. For example, majority of the cancer awareness walks takes place in Abuja and Lagos, which is the political and commercial hub respectively in Nigeria, and women in the rural and semi-urban areas are usually left out. The Nigerian Cancer Society, which is the umbrella organization of all NGOs and civil societies in Nigeria doing cancer advocacy, is actually doing a good job, and we feel that leveraging with them will actually further take this message to the grassroots where it is most needed. So there is need for synergy between them and also the First Ladies Against Cancer, which are actually doing wonderful advocacy and also funding cancer treatments, including ovarian cancer patients. So I think moving forward, they can actually further collaborate, synergize, and partner to see how we can take these messages to the grassroots, to those women that actually need it the most. Thank you.
Thank you. And Afrin, just briefly, this sounds horrible saying it briefly, but I know you have thoughts about our need really to have a focus on the role of women in society if we want to tackle this problem.
Yes, Frances, thank you. So yes, one of the main, most of our women rely very heavily on their husbands or the male members of the family to make the decisions, both in terms of finances as well as any other decisions. As much even going to visit the doctor, they have to ask for permission. So yes, we need to economically empower our women. This can be done through perhaps institutions giving them microloans for microfinance loans for startups or increasing vocational trainings. The other thing we need to emphasize is educating women. Once we educate women, these women will be in a position to voice, for their voice to be heard, and they can actually make informed choices. I think these are some things we need to work on, particularly in our society, which is very patriarchal, most of our societies, yeah.
Yeah. I find it quite fascinating that as a group, you've all trained to be medical doctors, yet here you are you're really taking the mantle now for advocating for change for women in your country. We're having to look at, working with NGOs, civil society, the role of women, is much bigger than just ovarian cancer. I'm going to let you decide who's going to answer this first, but why do you do it? And what help or support do you need to either directly bring about change or influence others to do so? Who's going to go first?
I think I'll go first, Frances. Thank you very much. For me personally, why I do what I do, and not just the clinical work, but do a lot of advocacy. We do a lot of fundraising for our patients, is because, I work in an environment where I belong. I see women like me, women my age. I see young women in the reproductive age dying from cancers, and they don't have the ability to fund their care. And we just have to change the narrative, because the figures are abysmal. The situation is really gloomy. And we realize that if we can't just sit down and expect these women to come to us. Even when they come to us, they cannot afford care. And so we decided to start talking about it. We have and decided to also do some advocacy as part of what we do. And that is why most of us have joined advocacy groups to see how we can benefit these patients beyond just caring for them in the clinical aspects. Thank you.
If I may go, I think it's been part of my evolution. I think in the beginning, you're concentrating on being a good surgeon or clinician. And as you grow, you realize you may get involved with policy, and policy doesn't translate into anything unless women know about things. So I think it's grown on me rather than me doing that initially.
Okay. And Afrin, any final comments?
Yeah, so for me personally, when I finished my residency as an obstetrician gynecologist, I was posted in a very remote area in Kenya. So I would see all these women coming to my clinics, and it would take me months to get them the care they needed, to refer them to appropriate facilities. We don't have any gynecologists there. So I would struggle. It was a struggle just to refer them for the necessary treatment. For me, I want, at least from my end, at least as physicians, we can make some sort of change to bring about some change, so we can, at least the women can get the necessary treatment they require. So in terms of how we can increase support, we need international support. The International Gynecological Society has really helped us. We've been training more subspecialists, and we've got a platform for advocacy, and in that aspect, we've got a lot of help from them.
Good. And we'll be hearing more from IGCS just shortly. So thank you very much, Dr. Aisha Mustafa, Dr. Afrin Fatima Shafi, and Dr. Tracy Adams. They'll be around for the Q&As as well. Taking on this study has been a huge challenge on many fronts, but one of the things we as a partnership with the Oversight Committee have had to grapple with is how to make the study as accessible as possible for groups and women to participate and to meet the needs of local teams. So I'm very pleased our World Ovarian Cancer Coalition CEO, Clara McKay, is going to outline for us some of those equity challenges and how we've dealt with them. Thank you.
Thank you, Frances. I'm just going to pull my slide up here. I think you can see that. So thank you, Frances. Thank you, Afrin, Aisha, Tracy, for sharing your insights. And they mirrored much, I think, of what Anmol shared with us too from those detailed surveys. But, we often talk about the data, and that is just hugely important. But I think these reflections are just hugely important because they highlight the fact that this study is actually about real people and, you know, the women and their clinicians that navigate just enormous, wide-ranging and significant challenges every single day. So it's, you know, I think we need to hold that right at the heart of what we do. I was really struck, and we've heard it before, but just the whole theme that runs through all of this work about affordability at country level, at individual hospital level, affordability for individual patients who don't have the coverage or the resource to cover their treatment. And I just can't imagine the sheer frustration that you must experience. And you talk about this kind of syndrome of disappearing patients, and it's just hard to fathom that that's kind of, you know, the result of this limited resource for these women. I thought also the point about political will just really, I think, is so essential. And not accepting the status quo. So I genuinely believe, and you know, I think we all are in it because we do believe that work like the Every Woman study will help us make that compelling case that politicians and health ministries and you know, can no longer really not acknowledge the significance of this disease. And on that point, the value and the importance and the significance of local data and local solutions, and not conducting a piece of work that is done in a country and then is taken out and, you know, fed into publications that are so removed from, you know, from the context of the country. But also the agency of women, the whole issue about health literacy, which is, you know, bigger than all of us in a way. And I really feel this is where we need, as a community, a global community interested in women's health and women's cancers, that collaboration across that piece is just essential, because it's a fundamental barrier to access if you don't have the health literacy or the agency to act on your for yourself about your health. So they're all really real and very deep and prevalent challenges, and thank you for kind of expressing them so eloquently. But we thought it also might be helpful to, at a slightly another level, but it covers much of what was discussed, share some insight into really the challenges of getting a study off this nature off the ground in the 24 countries that we're currently working with. And you know, we've learned a lot as we've moved the study forward, and guidance from our oversight committee, as Francis, I think, mentioned earlier, has just been invaluable in finding workable, practical, local solutions to some of the challenges that we face. And they've included really trying to meet a commitment to ensuring at country level we're involving the diversity of centers and hospital centers that exist within that country. So not just sort of urban centers. And this has really involved a lot of effort from our country leads to bring in sites, but we know it's crucially important to spend time to do that, to give us this true picture of the experiences of patients, as well as the clinicians that work with them. We have become translation experts, including languages and dialects that aren't recognized even by sort of mainstream online translation platforms. We've used local translators and volunteers where we can to ensure accuracy and that we provide local translations into local languages, which is incredibly important. But it's also the case that not all women, they may speak and understand the language, but may not be able to read it. So to address that, we've really made as many options available as we can by way of having the study implemented and the survey administered. So it can be administered by somebody else in a one-to-one setting. We've made paper copies available if that's what will work, secure electronic links to the questionnaire. So really covering as many bases as we can. And we've been mindful that the study is drawing on those that already work with very low resource, and even minor additional costs can have quite a significant impact in these settings. So the study does cover basic core costs for translations and ethics submissions. And very much linked to that, we wanted to ensure that the patients and the centers with the least resources can also participate in. And because of that, in some instances, we have found ways to put in a little additional support to resource to support admin and data data costs or input costs, so that resource isn't a small amount of resource isn't a huge barrier to participation. But it's also important, I think, and we've covered this in the previous presentation, that we actually important to recognize clinicians who participate in the study and give them recognition for that work. So having an equitable approach to publication opportunities is really crucial. And we, as we have today, see all of the participating countries and individuals as partners and make opportunities where we can find them and where it's appropriate for people to be authors and listed on studies. So overall, the challenge is about ensuring that we secure the integrity of the purpose of the study and the methodology, but balancing the needs of the countries, whether that be about approach or content. We've lost some countries and there have been delays along the way, everything from COVID, just really thinly stretched staff teams not being able to really kind of manage just even an extra task on their plate. We've had many countries are experiencing political unrest, so there's at times questions about the actual safety of the physicians and patients participating in the study. And sometimes people just leave countries or they emigrate. So it can be quite easy to lose the sort of momentum that we've established. But I think we've done quite well. So it's kind of all about being creative, collaboration, and partnership. And on that note, I want to introduce Mary Eichen, CEO of the International Gynecologic Cancer Society. And IGCS is just a hugely valuable partner with us on this study and a hugely valuable strategic advocacy partner. Anyway, and Mary, I think we've proven really that when we align patient and clinical advocacy objectives in the way that we've done on this study, that it's a pretty unbeatable formula. So I'm going to hand over to you and let you speak to that for a few minutes. Mary.
Great. Thank you so much, Clara and Francis, for organizing us. And of course, the team from the London Global Cancer Week. What a week and what a way to give such notice to global cancers. My name is Mary Eichen. I'm the CEO of the International Gynecologic Cancer Society. The World Ovarian Cancer Coalition has been a trusted partner of the IGCS for a lot of years, and I am grateful for them for bringing us into this very important study. I thought I'd start with just a little bit about IGCS, why we make such a great partner, who we are, and kind of our reach and our ability to be global in nature. So we are a member-driven organization. We have over 3,454 members. That may have changed by now. And we reach over 118 countries. So you can see here on this map, we do span the globe, and we are super proud of that and super excited to share some of this with partners like the WOCC. We have a nice balance of members from Asia, North America, South Central America, Europe, and then Africa, Middle East, and Oceania. We started a strategic alliance program, and this is where many of our partner organizations within this study really came about and to fruition. Many of them are on the steering committee, and many of them are participating sites. You can see our strategic alliance partners really do bring us an excellent spread of the world, in parts of the world where IGCS in the past has not had a lot of engagement. So we are very pleased to bring, again, this study to many of our strategic alliance partners. We have a reach and level of engagement now of over 10,000, along with our 3,500 members. So about 14,000 people we engage on a variety of levels. We undertook a major IT transformation project the last year to really get our arms around who is a part of IGCS, who are we engaging, how are we engaging them, and how many in that region are we touching on a regular basis. So this is very clean data, clean emails, clean contacts, and again, allows us to participate in projects like the World Ovarian Cancer's Every Woman study. This is, recently we've done an ovarian disparity survey amongst our physician members. Again, this just shows our ability to reach all aspects and corners of the world. We were really, really pleased with over 1,000 responses, again, well represented globally. We do mentoring and training, which again is where we found some of these amazing sites, places where we're doing surgical hands-on training in gynecologic oncology. These sites, seeing patients, really this study brought to them this full circle of the physicians we're training and the importance of the data that we'll get from this study for their patients. We train in locations that are either in green or orange, and our mentors are in high resource locations depicted here in purple. We have over 20 training sites. We have 40 fellows who are actively training at any given moment. 36 international mentors in those purple sites on the map that I showed, 43 local mentors, and 25 graduated fellows. And through this, we are extremely pleased of our accomplishments through 2021. We'll be updating these numbers in the coming 2 months. We have over 8,300 surgical cases now logged by our trainees, over 1,100 radical hysterectomies and 3,500 simple hysterectomies, again, logged in our surgical case. We've done over 500 plus echo tumor boards, which is a huge way in which we do a lot of our training and education. That includes over 750 cases discussed as part of this tumor board. We also have a patient advocacy network where we involve both patients and their families. Again, when you can reach over 14,000 individuals, that represents a lot of patients. We began what we call International Gynecologic Cancer Advocacy Network, IGCAN. And again, our stretch globally has really allowed us to reach patients and their caregivers around the globe. And then finally, of course, our MOU with the World Ovarian Cancer Coalition. Could not be more proud of this. Now it looks like 3 years, almost to the anniversary date. I really appreciate the friendship and collegiality of Clara and the rest of her team. They have embraced IGCS and my team, and it's just heartwarming to see what we can do together, especially through this low and middle income edition of our Every Woman study with them. So in the end, for all of us, it's about the women. Thank you again for your time. Thank you for the invitation to present, and to my friends at WOCC.
Thank you, Mary. That was excellent. Thank you so much. We are running a little late, but I think we could probably stretch to 10 minutes. We have some really good questions that have come in actually, so it would be really great to get some feedback from the panelists. So, Francis, there are a couple of just very practical questions. So I'll start with you because I suspect that there'll be people who are joining us that are interested in becoming part of the study. So it's can other countries join? Can new countries join the study? And a different question. But are we asking about risk, about women's risk of ovarian cancer and family history?
Okay, those are relatively easy ones to deal with. Yes, we are asking about women's risk factors, not only family history, but there is a question in there about their sort of gynecological history, use of oral contraceptive, breastfeeding, how many live births, and so on. So we do have some questions in there as well. In terms of can other countries join, at the moment our priority really is to get those who are involved underway. If there is a country that is very keen to join, we'd have to have a discussion about what resource and networks there are, and to what extent we can get things underway, whether we're covered by languages that we already have. We are keen to finish our initial data collection by the end of June next year. It is our aim and intention, though, that this study lives beyond this original phase of it, so that certainly the protocol and the means will be available for others to consider how they can do this. It's just whether or not their figures can be part of the global stats or not. And we've even had some of the countries who are participating talking to us about, can they continue data collection beyond the end of the study, and even is it possible to adapt the study for other types of cancer as well. So, but at the moment we have to focus on getting our 130 sites all collecting data and getting towards their minimum sample sizes. But we can, if need be, look at others, but we'd need to meet certain criteria along the way, I think.
Excellent. Sorry, did you answer the risk?
Yes. Yeah.
Okay, super. I was looking at something else. And Mary, just before there are some questions that I think are really suitable for our panel of physicians, but there was also a question that came in, and you may have touched on it, about gaps in gynecologic oncologists. And Francis, you feel free to jump into it. Will this work? And Mary, because I know you've touched on the work that your survey, will it help, I guess, to identify where there may be gaps in training, capacity, skills, that sort of thing? Oh, and you're on mute.
Very sorry. There's no doubt that there is a lack in consistency in training, as well as being able to find the right trainee in the right setting. So capacity assessment is huge for us as we think about where we expand our training programs to, but there is in fact a lack of consistency in training, and I think there's a desire to have that moving forward. And I would welcome the physicians here to comment on that as well.
Excellent, thank you. And Francis, quickly, will through the clinicians survey and the work that is part of the study help flag up from a clinician's point of view where there may be gaps or needs?
Via the lead clinician surveys, yes, it will do.
Yeah. So, thank you. Thank you. So we also have some questions, and I think this is quite a good one to start. So I'll read it out, and then I might just take it round to different people. So there's been a question about kind of variability and access to genomic profiling of tumors. So so the question is really, is there any chance within your settings of personalized care being delivered in the way it is in high settings, and what does that mean in terms of standard of care that you're trying to offer? So Afrin, I might start with you. So personalized care.
Yes, so in terms of personalized care, yes, if we are able to get the care we offer in a low resource setup versus in a huge country like Kenya, you have hospitals that have all the care. They have genetic testing. Patients can afford that kind of care, but then there's the other side where we don't have access to any of these. Tests are very expensive. We can't send patients, and then there's a limited
I think we may be
number
lost.
of drugs that we have access to. So it gets very difficult for us after. Sorry, am I audible?
You're okay.
Yes,
You were just breaking up a little bit.
Yeah, so it gets very difficult for us to treat these women, we run out of options. We don't know what to do after a certain point, then we just go back to palliative care, and we end up offering palliative care, unfortunately.
Tracy, in South Africa?
I think there's a lot of variability there. Genetic testing is available. It's very expensive, and I think it depends on the center. So the center that I'm working at, we do limited BRCA testing, so not the full testing. However, it's the translation of the testing, because we don't have PARP inhibitors available. They're too expensive. So what we're really doing it is for awareness for patients and to offer risk-reducing surgery if someone is BRCA positive, but we're not using it specifically for women with ovarian cancer, but more for prevention.
That's really interesting, actually. Thank you. Ayesha? And you're on mute. Oh, you're on mute.
Sorry.
That's okay.
Thank you very much. I didn't know I was muted. For us, we do not do routine genetic testing, whether germline or somatic. We also do not do the profiling, and so we generally still do the standard of care. However, there are private facilities that have the services available, but they are usually not affordable to the majority of patients. Thank you.
Thank you. Thank you. And Francis.
I just had a point that actually, you know, these personalized treatments, they're an adjunct to the standard of care. So in many settings, actually just getting the standard of care is the first important step. I think there's a great piece of work to be done about prevention as well, and we mustn't miss those opportunities. But yeah.
Totally agree. And I think I would say we did a piece of work last year looking at access to what it would be essential medicines. And, you know, one of the probably more pertinent challenges is ensuring that countries have access and there is availability of, you know, the basic treatments for ovarian cancer that we know, you know, have been around and are less expensive, but without them, as Francis, you've said, you're not going to build anything on top of that foundation if you don't actually have a kind of robust standard of care approach. So I have a question. So it says, following conclusion of the Every Woman Study LMIC edition, are there avenues for partnering with national governments to aid in creating awareness in different nations and leveraging pharmaceuticals to make chemotherapy agents more accessible and available in LMICs? So I think kind of two things. I do, and I would be, I guess, interested, does this come back to that needing to have the political interest to want to, you know, to feel that women's cancers, ovarian cancer is important enough to put an effort into awareness raising? Is that, so I'd sort of put that out to the panel. And I certainly think from our perspective, what we would really greatly welcome would be sort of, you know, national priorities around ovarian cancer and awareness raising. And I guess the second point to that would be about the UICC initiative around access to oncology medicines, the ATOM initiative or partnership that they're starting. And I think that very much is about that, making chemo agents more accessible and available in low and middle income countries. But kind of picking up on the first point, I guess, about awareness and, you know, does it come back to political will, Tracy? Is it because women's health and cancers are less prioritized, and so or is ovarian cancer a little bit of an orphan cancer in the mix as well?
I hope not. I think what, for me, the Every Woman Study, LMIC, if done, the country leads could really write their own independent papers and take that to government as a start. Really just to show what we have. And it's a challenging situation, but I think it's a start to present some kind of information. And hopefully that will create some political will, as opposed to no data at all.
Thank you. Does anyone else want to comment on that?
I would add in again, coming back to the standard treatments for ovarian cancer are on WHO essential medicines list. So we really do have an opportunity to join in with others who are already working on this, but to try and amplify and, you know, reach further and bring life to, if you like, some of those discussions, so that ovarian cancer is also seen within it.
Yeah, agree. So we have a question as well about the variability of surgery. There are two questions, so I'll probably split it up. One, I think, Francis, there was an earlier question about variability of surgery between countries, and if we see, and Anmol, you may want to answer this too. Have we to date seen anything in our data that would suggest that there are variations between the countries in terms of volume or access to?
It's too early to look at comparative data, really.
Yeah.
But I think the country leads are best placed to sort of answer this. I think it probably depends on where you are as to, you know, and what theatre time you have, and, you know, do you get the chance? Do you get the chance to do the surgery you want to do? There's a question.
Exactly. I see people nodding, actually. So if anyone wants to come in on that, please do. And then the other part of that question, oh, go ahead. Tracy, please go ahead.
I think I just wanted to add to the thing that with ovarian cancer, I mean, it's really cytoreductive surgery, which can be quite a long surgery and intensive. And I think in a lot of low middle income, certainly in my setting, even if we have the skill to do it, we may not have an ICU bed. So often our decisions are made on
Right.
resources, not only on skill, but the care after for that patient. So when I say the people are competing, we may be competing with other surgeons for a limited number of ICU beds. So elective surgery can also be very challenging with ovarian cancer.
That's really interesting.
It's a combination of surgical skill, ICU, you know, it's not just one thing. It's quite a complex procedure.
Interesting. Ayesha, did you want to comment on that? I see you nodding.
Yes, I would just wanted to add that actually for us also in Nigeria, everything Tracy have said also matters a lot. And in addition, we also need more skill sets, and big thanks to IGCS that we have started the fellowship training in oncology in Nigeria. And in addition, also the equipment to be able to do this surgery. Equipment, as even basic equipment sometimes could be the challenge. And yes, ICU care for post-operative. This is after the patient has been able to afford the surgery.
Yes, yes, yes. It just goes back to that kind of the barriers behind the barriers. Every time you get through one barrier, there might be something else in front of you. Mary, did you have any comments on that sort of rates of surgery? Do you, from your perspective at IGCS?
Yeah, you know, the trainees are required to enter their cases, you know, into a formal database. And we do see a variability in the types of cases that are being done, and the surgeons, you know, abilities to, you know, really care for these women. Obviously, radical hysterectomies are incredibly important with the prevalence of, you know, cervical cancer disease, some of the uterine cancers. But we really, really have to better understand what are the capacities to train them in that region to do this? What is the hospital support for this? Right? They can't just be on an island wanting to do this alone. The anesthesia report or support, blood bank support. It's the team in order to really do complete training. The pathology, so important. So we really do try to take all of this into account when doing our training, include the entire team in our virtual tumor boards, and honestly doing mentoring beyond just surgical training now because of the importance of pathology and other things.
Interesting. Yeah, I think that point about it's a team, and it's, you know, it's a range of disciplines, and it's, you know, it just, you can't, without the pathology, you can't, you know, segment your cancer. So it's just, you know, incredibly important that that all kind of come together well. So I think what we'll do is we'll bring it to a close there. So thank you for everyone that's attended. We've had really an overwhelming level of participation in this session, and I think that bodes well for the study and bodes well by way of the level of interest that there is in improving outcomes for women with ovarian cancer in low and middle income countries. So that's been really encouraging. If we haven't answered your question and you have questions that about the study, please do get in touch. Again, there's a QR code with will take you through to an information pack about the study. And again, please reach out directly and contact any of us on the team if you have any further questions. I want to thank all of the panel members who are here today. You have and who have done video recordings if they haven't been here in person. It's just been an amazing contribution, and I think a really full and complete presentation of the complexity, but the importance and the potential value of this study. So it's been really wonderful to take part. And Francis, thank you for all your work in pulling this together. I know it was a big task and well done, just a brilliant job. And finally, to thank London Global Cancer Week for allowing us to this opportunity and taking the time to share our work with you all today. So on that, thank you all very much. And
thank you. Nice to see you.
Nice to see everyone. Thank you.